Hi, Bacho. Let's talk about NACO guidelines for management of HIV in pregnancy. So, any female who is HIV positive, either during pregnancy or labor or during breastfeeding, they have to be given ART irrespective of the gestational age. This ART should be comprising of three drugs: lamivudine, tenofovir, and dolutegravir. These three drugs, they have to be continued throughout life, not just during pregnancy, but throughout life, the ART has to be continued, irrespective of the CD4 counts. NACO says that between 32 to 36 weeks of pregnancy, you have to check the viral load of the patient. This is not because I want to decide the mode of delivery. This is because I want to assess the risk of infection to the fetus, to the baby, whether it is going to be low risk or high risk. The mode of delivery as per NACO is always vaginal delivery in HIV patient. Cesarean section is done for obstetrical reasons. And during vaginal delivery, there are certain things which you don't have to do. For example, no ARM. Do not go for prolonged labor. Instrumental delivery should not be done, and fetal scalp pH monitoring should not be done. After delivery, nasogastric suction of the baby should not be done. As far as cord clamping is concerned, cord should be clamped the moment the cord pulsations stop. The cord clamping should not be delayed for a very long time, right? The moment cord pulsations stop, you have to do cord clamping. Then once the baby is born, breastfeeding can be done. Breastfeeding is not contraindicated as per NACO, but in the initial 6 months, it has to be either exclusive breastfeeding or exclusive replacement feeding. Now, based on the category of infant, whether the baby is low risk or high risk, and how do we decide that? If the viral load between 32 to 36 weeks, when you had checked, if it was less than 1000, the baby is low risk. And in such case, you have to give them one drug, and that is syrup nevirapine, which has to be continued for 6 weeks, irrespective of the fact whether the baby is being given exclusive breastfeeding or exclusive replacement feeding. But if suppose you were unable to do the viral load, or viral load came out more than 1000 copies, or if the mother was not on ART, or if she is a freshly diagnosed case of HIV within 6 weeks of delivery, in this case you have to give two drugs, that is nevirapine and zidovudine, to the infant. And in this case, if you are giving exclusive breastfeeding, then the drugs have to be given for 12 weeks. If the baby is being given exclusive replacement feed, then it has to be given for 6 weeks. So these were the guidelines of NACO for HIV management in pregnancy.